Hi there, my name is Nicole McLaughlin. I am the Director of Psychiatric Neurosurgery at Butler Hospital, and I'm an Associate Professor at Brown Medical School. I want to thank OCD Rhode Island for inviting me to give a talk this year. And this year I am talking about transcranial magnetic stimulation, or TMS, for obsessive compulsive disorder, or OCD. So just first to start off, I just want to explain what neurotherapeutics are. So neurotherapeutics are essentially interventions that are designed to impact the brain or the nervous system in some way. So some examples of these are invasive, what we call neurotherapeutics, like deep brain stimulation or lesion or ablative surgeries, or non-invasive neurotherapeutics like electroconvulsive therapy, transcranial magnetic stimulation or TMS, transcranial direct current stimulation or TDCS, as well as low intensity focused ultrasound or LIFU. What I'm going to talk about today, as I noted, was really focusing on transcranial magnetic stimulation or TMS. So when we think about OCD, we really think about the brain and how different regions of the brain interact. So it's not necessarily just about one region. Really, it's really about how different areas of the brain interact. And you can see in this picture, it's pretty complex. So, years ago, we really thought maybe there was one circuit or a couple areas of the brain that were really important in OCD. And so when we look at research studies, we do see that there are consistent areas of the brain that are either potentially overactive or larger than other areas, or areas that are underactive or smaller than other areas. And although those research studies may differ a little bit, what we see are pretty consistent findings in terms of regions. And some of these are shown here. And really the important takeaway from this is that we're looking at these circuits. And the goal of neurotherapeutics is really to impact some of these circuits in different ways. And when we impact a different area of each of these circuits, what can happen is we can have behavior change. So we can have change, improvement in OCD symptoms. So some of the structures we talk about, and again, we don't have to kind of learn all these right now, but we talk about some cortical regions. So cortical regions are the regions that are kind of on the top of the brain, so closer to the scalp. So those are things like the dorsolateral prefrontal cortex, which is over here, the orbital frontal cortex, which is right behind the orbits of the eyes, the cingulate, which is a little bit deeper down, but kind of below here and kind of wraps around. And then the supplementary motor area or the pre-supplementary motor area, which are right in front of our motor strips that go down the side of our brain here. So kind of right around here. And then we talk about subcortical regions. And subcortical regions, like it sounds, are kind of subcortex. So below those cortical regions. So these regions are areas that are really deeper in the brain. So areas like the basal ganglia, so things like the caudate, lobus pallidus and putamen, the thalamus, and the amygdala. Those subcortical regions we can reach really well with some of these invasive techniques. So things like ablative brain lesions or deep brain stimulation, we can hit either cortical or subcortical regions. Things like when we talk about TMS or transcranial direct current stimulation, TDCS, it's a lot easier to hit those cortical regions because we're doing something outside the head. We're not sticking anything in the brain. And so it's much easier to hit those cortical regions when we're just doing something on the scalp. So when we talk about OCD treatments, we're still talking about starting with medications. So commonly serotonin reuptake inhibitors, as well as cognitive behavior therapy, specifically exposure and response prevention, or ERP, as well as a combination of the two. So those really are still our gold standard treatments for OCD. And about 70% of people with OCD will experience at least some benefit from ERP, medication, or really a combination of the two. But there are still some patients who don't benefit from these treatments or who only experience a minor reduction in symptoms. And so up till now, or maybe the past 20 years, alternatives have been limited. So it's kind of like, okay, medications don't work, ERP or therapy doesn't work. What do we do next? So, I mentioned this invasive stimulation. Invasive stimulation can work really well. I'm not going to go into that too much now. You can get good responses for patients who are really ill, right? So very, very severely ill patients who really have significant difficulty functioning. They can respond really well to things like deep brain stimulation or lesion procedures. However, there are some patients who may not have mild symptoms, but may not have really, really severe symptoms. And we don't have fantastic alternatives there. We haven't in the past. So when we talk about non-invasive stimulation, these techniques are quite safe. And as compared to invasive treatments, a vastly larger pool of patients might be candidates for these. And cost and logistics of care for these are relatively favorable. Why not? So the thing that we still come across is it can be a little bit challenging to get some lasting effects on symptoms, functioning, or brain circuitry using some of these non-invasive methods as compared to brain lesions or implants like DBS. So like I said, I'm going to talk about transcranial magnetic stimulation, or TMS. So TMS is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain. So what that means when I say non-invasive, it means we're not sticking anything into the head. So you can see an example here. I'm going to show some more photos in a minute. Essentially, there's an electromagnetic coil that goes on the outside of the scalp that induces a magnetic field that sends some stimulation into the brain through the scalp. Over the past decade, or even 2 decades, TMS has really emerged as a new option for OCD treatment and has progressed from a purely experimental treatment to a more widely available therapy backed by research studies demonstrating effectiveness. So TMS, right now, how we're looking at it, is TMS is for people who have already tried first-line treatments like ERP and/or medication, like I mentioned, and are still struggling. And what we think is that TMS should still be provided alongside medication or ERP as an add-on or adjunct to therapy. So we're not saying kind of get rid of the therapy, get rid of the medications, but kind of, stay on medications if you're able to, and the side effects aren't too bad, and continue doing ERP, and then we add on TMS to that. So as you see from these photos here, TMS is really not a new idea. So if you look back to the 1800s and the early 1900s, you can see some photos here of people attempting to do things like TMS. So experimental equipment, you can see kind of 2 coils on either side of this person's head, as well as coils around this person's head in 1911. And so really, things like this were done way in the past, but certainly not like we're doing now. In 1903, TMS was also patented as a treatment. So you can see here, there's a coil on the back of this person's head here, kind of a little bit further back from where we would put it, but actually along the same line as where we would put it for OCD treatment now. Interestingly, where this was patented in Vienna, it was just down the street from Sigmund Freud. When we look at some timelines of TMS, we can go back to the 1700s, where we discover that nerves carry electrical energy. In the late 1800s, as I noted, there were some experiments with electrical brain stimulation. In the 1950s, there were some studies looking at magnetic fields used for nerve and muscle stimulation in animals. We move up to the 60s, where they used to stimulate muscles among humans, which they still do today. In the 1980s, the study and introduction of the first TMS device. And in 1985, the first successful TMS procedure. In 1987, there was a release of TMS safety guidelines. And in the 1990s, we really came to understand that TMS can be safe and effective. In 2003, Canada approved the use of TMS therapy. And then in 2008, the FDA in the US approved the use of TMS therapy. And this is for depression, what I'm talking about right here. And then 2010, NIH shows the effectiveness of TMS therapy. 2013, US health insurance companies began to cover TMS, but primarily for depression. And then in 2017, TMS therapy is widely used as a safe and effective depression treatment. So I'm mentioning depression all along. So depression is really, in the past, the primary treatment, or TMS has been primarily used for depression. It's only more recently that we've started to learn how TMS could be effective for OCD. And I'm going to talk about that a little bit more. And now the FDA has approved OCD, has approved TMS as a treatment for OCD. And what you can see here is that, so this on the left is actually research articles going back from 1999 to 2022 about the use of TMS in OCD. And you can really see such a difference here over the past 20 years of very few articles back in 1999 up to quite a few articles just last year researching TMS for OCD. And then what we can also see is the TMS stimulator market size by type from 2015, anticipated up to 2026 and continuing to grow over time with different types of TMS, which I'll talk about in a minute. So when we talk about TMS, there are a couple of different treatment components that I'm going to discuss just so you have an understanding of what we're looking at. So first we'll talk about the device or the coil. So like I said, TMS delivers magnetic waves to the brain, right? So we can talk about something called repetitive TMS, and this is something also called RTMS, and this is used for treatment of depression as well as for OCD. And RTMS essentially means that you're sending a repeated series of pulses to the brain. RTMS can be used to target areas of the brain closest to the surface, so those cortical areas like I was talking about, and is sometimes referred to as surface TMS. Now, there's something also called deep TMS, which is a little bit newer, which also delivers a repetitive series of pulses like repetitive TMS. But the design of that deep TMS coil allows for these pulses to reach deeper into the brain, so potentially hitting some of those subcortical areas, and target areas that are out of reach for standard RTMS devices. And so what I'm talking about here are more kind of treatment or intervention types of TMS. There are also single pulse ways to use TMS that are used for research purposes, but I'm not going to go into those right now. There are a bunch of different TMS coil designs that deliver these magnetic pulses in different ways. So you can see some examples here. So here's the photo that I showed before, which shows holding a coil against the brain and delivering the energy to the brain that's changing, what's happening in the brain there right below the surface. And these are some different coils that we see here. Different shapes. And you can see these are types of figure 8 coils that kind of deliver energy in different ways. And there are a whole bunch of different TMS coil designs. So here are some stimulation models of 50 TMS coil configurations. And so you can see they range here from very small, just kind of ring coils, all the way up to these more figure 8 coils that I was showing on the other page, up to ones that wrap around. And so there's all these different ways that we can design these coils. And essentially what that means is that those then deliver that energy in different ways to the brain. And so what these maps are what we call electrical field distribution. So what happens in the brain when we're putting different types of coils on. And you can see depending on the shape of the coil, you can see that those electric fields are different in the brain. So some of them are very, kind of overlap with large areas of the brain. Some of them are much more focal or only hitting small areas of the brain. You can see there's such a big difference depending on which type of coil you use. And in addition to the device or the coil, we can talk about parameters. So the frequency means that, are we getting brain activity increase or decrease? So there's different ways we can adjust the frequency of TMS. And so for example, when we talk about low frequency TMS, or for example, 1 Hertz TMS, we think that this is inhibitory. So this may actually reduce activity or decrease activity in the brain, or at least different areas of the brain that it's hitting. And then we can talk about high frequency TMS. So this is 10 Hertz or more, and we consider this excitatory. So we may be increasing brain activity in that way. There are more recent experiments on the use of different types of TMS in the brain, in the human motor cortex, like I note here, as well as different areas. And that's using something called TBS, or theta burst stimulation. And there are also different ways we can use theta burst stimulation. And theta burst stimulation cuts the time of the treatment sessions, which I mentioned below, and I'll talk about in a second. And there's something called intermittent theta burst stimulation, which can have facilitatory or excitatory effects, or continuous theta burst stimulation, which seems to, for the most part, have inhibitory effects. And when I say for the most part, it's because it's not that straightforward. So different research studies may show, changes in connectivity or different things depending on even age of development in terms of these different types of effects. But this is kind of typically how we think of this. Levels of TMS are also individually determined based on motor threshold. So what typically happens is when someone comes in to get TMS in the clinic, they will have motor threshold testing. And essentially, the clinician, typically a physician, will use one of those coils, and they will stimulate the motor cortex. And what they're looking for is a response of some kind in a different area of the body. So for example, they may be looking for a signal in your hand, right? So we put a coil on the motor cortex. We may move it around to figure out where that motor cortex is and how excitable your individual motor cortex is. And what happens is when we stimulate that area, because we're directly hitting the motor cortex of the brain, you can either get an effect on something that's measuring motor activity in a different, in your hand or your foot or your toe, or you can actually see movement in the body. So you might see a little twinge in your finger or a little twinge in your toe when we hit the right spot at the right level. And we can then use that individual level to alter the threshold for TMS in the rest of the brain. So we may start off in the motor cortex and we may say, okay, this person's level is this, and we're going to use that level to do treatment on the rest of the brain. So this is what I'm talking about here. So we can probe motor cortex excitability. And so you can see here, we put something over the motor cortex. You can see that it then may impact, for example, we may see an effect, for example, on the hand. And we can either measure that, for example, on a computer screen by hooking up some electrodes to the hand, or you may actually see movement in just different areas of the body, depending on the protocol that's used. And then another thing we talk about is target. So early OCD studies targeted the dorsolateral prefrontal cortex, because that was the area of the brain that was used in depression. And that's still the area of the brain that's typically used when we're talking about depression treatments. And so they said, okay, well, that works in depression. And, we've been using that all the time in depression. So let's try that with OCD. It didn't seem all that effective. There are some studies that do show that it was helpful, but really it was variable. It didn't seem to be significantly helpful all the time like it can be in depression. So investigators really started examining other targets based on the neurocircuitry implicated in OCD and related disorders. And so with OCD, while some studies can show abnormalities in the dorsolateral prefrontal cortex, that's not one of the brain regions that kind of shows up when we're looking at OCD circuitry consistently, although again, it can sometimes. And so really they looked at the circuitry based on neuroimaging and they said, let's try some different areas and see if we can get different effects with TMS. And so, for example, some of those areas include things like the supplementary motor area, which I had mentioned earlier. And so that's an area right in front of the motor cortex. And that is actually an area that is shown, if we stimulate that area with TMS, we can show change in OCD symptoms. In addition to that area, researchers have examined other targets like orbital frontal cortex, which I mentioned earlier, which is again, the area right behind the eyes. Similar to the supplementary motor area studies, though there are only a few studies targeting the OFC, results are also promising of targeting areas similar, around that region. So this is a study that we carried out that was actually targeting the supplementary motor area. So you can see me with the coil on my head, and that coil was hooked up with these wires to this big MagStim device. And we put that coil over the supplementary motor area to deliver stimulation in an attempt to change OCD symptoms. And what we can do with targeting is we can target in a couple different ways. So what we can either just target based on scalp and locations on the scalp, for example, using something like an EEG cap, where we have different areas and we might measure the scalp and how big the scalp is and say, okay, it looks like based on your scalp size, that this might be the best area for you when we measure it out. We can also target based on neuronavigation. So we might get an MRI scan of the brain. Typically, when doing it clinically, there's a couple different ways to do it. You can either base it on anatomy, so taking a picture of the structure of the brain, which is what you have here. Or we can also take a picture of the functioning of the brain and say, okay, well, while we're doing a certain task or at rest, what areas are kind of lighting up in the brain based on changes in blood oxygen levels. And we can target in those different ways. So in this study, as an example, we targeted using anatomy. So we went in and we got an MRI scan of our participants' brains. And then what we did was we said, okay, where's the pre-supplementary motor area? And we based it on anatomy. So we had different ways to look at that. You can see this crosshair here where it says PSMA is the pre-supplementary motor area. And then we can do a reconstruction of the entire brain, which you can see here on the top left. And it'll show kind of where we think that point is where we should stimulate. And then what we would do is we use kind of a fancy camera. We line up the coil and we can see that moving on the computer screen and kind of showing where we're targeting, where we want to hit it. So we're consistent. And then we do that same thing every day. So in this study, for example, we did it every day for 2 weeks. I'll talk more in a minute Clinical treatments for TMS are typically longer than that, but for this research study, we did it daily for 2 weeks. So in terms of current approvals, the U.S. Food and Drug Administration, or FDA, has cleared certain combinations of devices, protocols, and target areas of the brain to be used in treating OCD based on research studies that have been done. The FDA cleared parameters for OCD treatment using TMS. So there's 2 of them. So there's a deep TMS device, specifically either the BRAINSWAY DTMS H7 coil, which has been approved now for a few years, or the MAGVENTURE Cool DB80 coil device. Both of these devices use high-frequency stimulation, and they're targeting typically the DMPFC, or dorsal-medial prefrontal cortex, or the ACC, which is kind of, we target up here in the midline, right in the middle of our brain here, and it kind of gets a little bit deeper into past where we were in that study a minute ago, to try to hit some areas that are a little bit below the scalp. And so as an example, so BRAINSWAY was FDA cleared in 2018. And so this is an example of a BRAINSWAY device. And you can see it has a, kind of a big device. It's a little bit different than that coil I was showing you. And essentially that coil is inside that device. But that makes it a little bit easier to line up versus trying to adjust a coil with a stand. And you can see that this deep TMS technology, which I mentioned, so the deep TMS is designed to kind of try to go deeper into the brain, includes a patented H coil. So I mentioned there are different types of coils. So this has an H coil held inside a cushion helmet that's fitted onto the patient's head. And once activated, that coil sends a magnetic pulse that acts to regulate the brain's neural activity. And so I mentioned earlier that we typically recommend that you continue doing therapy when getting TMS. What these approved treatments also include is a brief personalized provocation or exposure. So for those of you who have done ERP, you will know that typically in ERP, there's some sort of exposure. So for example, if you are concerned about contamination, we may say, okay, here's a dirty object, or I want you to touch this doorknob or something like that. And during these TMS sessions, there's typically a personalized provocation or exposure, similar to what you might see in ERP. And we think that might activate relevant areas of the brain for OCD. And then once that provocation or exposure is done, there's an 18-minute TMS treatment. And a full course of this type of treatment usually requires daily sessions. So once a day, every at least 5 days a week. So weekdays over a 6-week period. So you can see there's kind of a layout here of a provocation design. So for example, we might have a patient come in, we do a screening, we kind of get a sense of what's going on, making sure that they might be eligible. We also design the provocations. We might talk about different symptoms that someone has and come up with a way to do those exposures during those sessions. And then you might do 6 weeks of treatments, 5 treatments a week. So for a total, for example, here, this says 29 treatments. Each session typically takes 30 to 40 minutes total. So that includes provocation administration, plus that 18-minute TMS protocol. And to assess progress, we typically will definitely look at OCD symptoms at baseline, so before someone gets treatment. And then we may look at it each week or at the end of certain types of certain weeks, depending on what clinic you're going to. And so here's an example of, kind of field models for deep TMS. So you can see that this type of TMS, we think is going a little bit deeper into the brain. So it's not just hitting the surface here, it's going deeper. Now, the tricky thing about deep TMS is that you can see we're kind of hitting a lot of the brain, right? So when we talk about some of these other coils that are only hitting the top area, and they're not going as deep, they look to be a little bit more localized. So you're more likely to hit a smaller area of the brain. Whereas these deep TMS, to get deep, they end up hitting bigger areas of the brain. What BRAINSWAY has seen using this coil is that they're seeing significant change in OCD symptoms. So if there was a double-blind randomized controlled study published in 2019, and they took patients and they were randomized to either 20 hertz TMS or sham. So sham essentially means it looks like you're getting TMS, but you're not actually getting active TMS treatment. So patients didn't know which group they were in. And what they saw after 6 weeks of treatment, there was a statistically significant improvement in OCD symptoms for the active treatment group compared to the sham group. So you can see this response rate, about 38% in the active group as compared to 11% in the sham group. And then there were partial responders. So this first full responders, what they called full responders, meant that they had a Y-box reduction of greater than 30%. And that was, again, 38% to 11% in the sham. Those who were partial responders, so not quite 30% Y-box reduction, but at least a 20% Y-box reduction, was closer to 55%. And then the sham group did also go up around 27%, but there's still a difference there. What we see, what we have seem to see in kind of clinical settings, it might be a little bit lower than this. But this is still kind of, this research, although it's FDA approved, is still evolving. So we're still learning information about this efficacy in treating OCD. And then more recently, MAGVENTURE, which is just a different type of device, different type of coil, was cleared in 2020. So you can see that this device is a little bit of different shape. It doesn't quite have the same structure or device as the BRAINSWAY coil. And you can see it kind of shapes over the head, but it's essentially hitting a very similar region. Now, when we talk about safety, TMS is quite safe. So, when we think back to TMS being used for depression, so one of the earlier stimulation techniques that I mentioned earlier in these slides was ECT, or electroconvulsive therapy. And ECT kind of is still used today and can work really well for patients who have very severe depressive symptoms. But it can be really scary for patients, and it can have a fair amount of cognitive side effects. So ECT is essentially delivering electrical stimulation to the entire brain at once. And so what we see there is you can have some cognitive side effects. You may have some trouble thinking for the time in which you're participating in ECT, although probably not long-term cognitive side effects. What we've seen with TMS for depression is because really we're hitting a smaller area of the brain. We're not hitting the entire brain. And we see really no cognitive side effects. And typically there's not much in the way of adverse events. So we might get some headaches. The risk that people have been concerned about is seizure, but even this risk, as we've seen over time, is quite rare. So, for example, at our Butler Hospital TMS clinic, which has been treating depression for quite some time, we've never seen a seizure there. So while it's a possible risk, again, very rare. There's also some potential treatment changes. So we might get overactivation, so mania symptoms, or exacerbations of underlying psychiatric symptoms. So occasionally, when we've had patients with OCD, for example, going in and they're getting treatments for depression, their OCD might get exacerbated, for example. And in that case, typically you would stop the stimulation, and typically those events would be resolved if there's a big change or a big side effect. But for the most part, quite safe. We're not seeing negative cognitive side effects. And so this is really a great alternative for patients who have not had full response from medications or behavior therapy. Just something to note, we are kind of trying to move forward even more with research. So like I noted, TMS can be time consuming, right? So you have to come every day for weeks at a time, right? And it's a fairly short amount of time each day, but that's especially for someone who might be working or have a family, that can take up a fair amount of time. Now, certainly if it works, it may certainly be worth the time and a good trade-off. But we're also trying to think about ways in which we can speed that up. So can we make those sessions shorter per day? So for example, if we do theta burst stimulation in that study that we did, each of those sessions alone was about 45 seconds. And so the stimulation time was much shorter. So instead of 18 or 20 minutes, it was less than a minute. And so patients had to be in the clinic for less time, but still every day. There are also some protocols that are starting to look at kind of accelerated TMS. So for example, instead of coming every day for 6 weeks or 8 weeks, for example, we might have someone come in for 5 days, but do stimulation multiple times per day. So this study did it, basically almost all day. So these were long sessions. And so they would do theta burst stimulation, take a break, do it again, take a break. And they would do that every day for 5 days. And they did see changes in symptoms after that. So there is a potential there. You're kind of doing more intensive treatment in a shorter amount of time. So maybe you would take a week off of work, just like you would do in engaging in a day program for treatment, for example, versus coming every day for 6 weeks. Or maybe there's a way we could also shorten this so you don't have to do so many sessions per day. So the takeaway is we do have some strong neurocircuit-based therapies. The many are invasive, which I mentioned earlier, and only appropriate for the very severe. But really, over the past 10 to 20 years, we've been developing some of these more novel techniques that may be used for more patients. And really TMS is one of those. So again, it's been used for quite a while now with depression. There are many clinics that are using it for depression, and now more and more clinics are starting to use it for OCD. It's a little tricky. Sometimes, we don't have consistent insurance approval for OCD that hopefully we'll get there like we have with depression. And we are actually starting to do TMS for OCD at Butler Hospital as an add-on. We now, like I said, we have had a TMS clinic for depression for quite some time, and now we'll be starting to do OCD treatments with the MAGVENTURE device. Thank you.